So hello and welcome everyone to today's webcast. My name is Morten and I'll be your host today. So before we get started, I'd like to welcome Marco Mara, who will be our presenter. First, I'll give a short introduction to the Anybody modeling system, and after that, Marco will take over and present his work. Marco Mara is currently an assistant professor at the University of Twente, but most of the work that you're going to see today was done at Radboud in Nijmegen. And it's some exciting work you will see today. Marco is probably one of the best Anybody experts in the world, and he's done a lot of knee modeling during his time in Nijmegen. I think he's going to talk about most of that work here. So first, a short introduction to what the Anybody modeling system is, if there is a few users or listeners who don't know what it is. Basically, the Anybody modeling system is a simulation tool that you can use. What you use as input is either measured data or prescribed data in the sense of forces and kinematics. And then you run simulations to output body loads, joint loads, and muscle forces. The Anybody modeling system can be used in a wide variety of applications, from product design and optimization, economic analysis, surgical planning, load cases, and for normal motion analysis. A typical application of the Anybody modeling system would look something like this. You would come with your own forces and motion, or prescribed motion, or measured forces, or could be from a force lab. A mocap lab, for example. Then you would use maybe some of those existing body models or build your own, and you would use maybe some environment. In this case, here it's an exoskeleton. And combining those things, you can run different kinds of simulations and analysis to give you the internal body loads. Typically, that would be muscle forces or joint forces. After the output from Anybody, you could also do some sort of post-processing that could be use the input for final element tools. And you can close the loop completely to do design optimization, to optimize your device. I hope this gives you a little bit of an insight here before we get started to what the Anybody modeling system is. And with that, I will give the word to Marco. So I'll first disable my webcam here, and then I will unmute you, Marco. I hope you're on the line. So Marco, can you hear me?
Okay, Morten, thank you for your kind introduction. So welcome everybody. My name is Marco Marra, and I'm a researcher at the Department of Biomechanical Engineering at the University of Twente in the Netherlands. So first of all, I would like to acknowledge all my colleagues in the Biomech Tools project, which is an ERC funded project. So first of all, to motivate this presentation, I'd like to give some motivation why we do musculoskeletal modeling, because essentially it's a very great tool to assess the musculoskeletal mechanics, and we can use it to assess interesting parameters in the musculoskeletal system completely non-invasively and under actual physiological loading conditions. And this is typically not possible in other clinical trials, for instance, or in cadaveric studies. So these musculoskeletal models have a great potential as diagnostic tools, and can also aid in the pre-operative planning of surgery. So as an outline for today's presentation, I would like to start by recap on the development and validation of a subject-specific modeling framework for total knee arthroplasty. And then I would like to show you some techniques that can be used to accelerate the actual simulations of these models. And following, there is to talk about applications, actual clinical applications of musculoskeletal modeling, and we'll see some problems related to sagittal alignment of the total knee arthroplasty prosthesis, and last is also some application in patellofemoral instability problems, something related to trochlear dysplasia. So a very brief recap on total knee arthroplasty. This is a very successful procedure. It's meant to relieve pain in patients with osteoarthritis. And the ultimate goal of every TKA operation is to restore the function of the knee. However, despite its success, there is still a large amount of patients who are not entirely satisfied with this prosthesis. And the reason can be very diverse, but they also include implant-related factors and such as alignment, and also surgical technique and the actual experience of the surgeon who performed this operation. So for that reason, we in 2014 we developed this patient-specific modeling framework for total knee arthroplasty. And this is essentially an effort to make a model of the knee joint which is replaced by prosthesis, and to be able to estimate relevant parameters such as muscle forces, ligament forces, and articular contact forces. Thanks to the use of a technique called force-dependent kinematics, we are able to actually simulate the biomechanics of this of the model all at the same time in the same simulation. So we validated this model using experimental data sets from the Grand Challenge competition, and this gave us a great amount of confidence because the estimation of tibiofemoral forces were actually pretty good. And we could also validate the sagittal plane kinematics using a single plane fluoroscopy provided in the same data set. So what a typical analysis with this patient-specific model look like is depicted in this slide. So essentially, we use motion capture data in the form of marker trajectories over time, and we can use this to run an inverse kinematic analysis. So basically, the joint angles of the musculoskeletal model are optimized. These then are fed into inverse dynamics model together with ground reaction force measured using force plates. And these two ingredients essentially are required to run an inverse dynamics, which typically can be used to estimate muscle forces and joint reaction forces. However, we also enhanced this analysis using force-dependent kinematics. With this technique, it is possible to also calculate at the same time ligament forces, contact forces, and the kinematics of the knee joint under the assumption of a quasi-static equilibrium within the knee joint. So all the details of this model were already presented in a previous webcast presented by Dr. Michael Skipper Anderson. So for those interested in the details also about the validation, I would suggest to search for this video, which is still available on YouTube or on the webpage of anybody. So this brings me to the first topic of today, which is about surrogate contact modeling. So we talked about acceleration of simulation, and this is quite an important topic because simulation of a model with force-dependent kinematics and which calculates also contact forces requires some larger computation time than typical inverse dynamics model. And the time is actually spent on the algorithm to find the closest points in the contact detection. So the idea was, can we replace the default contact model with a surrogate contact model so that we can speed up the computation of the contact forces? Essentially, we are seeking for the loads out of two contacting bodies knowing the position between the two contacting bodies. So the assumption here is that the loads will only depend on position. So we are making a purely elastic contact model. So we cannot take, for instance, dynamics effect into account or viscoelastic properties. So the approach that we took was to make a artificial neural networks based model, which takes samples obtained from the original contact model in the any-body model. So we sampled several hundreds of thousands of points, possible configuration. So we then trained artificial neural networks using MATLAB toolbox. And this neural network basically learned the relationships between the loads on the medial and lateral side of the prosthesis and the positions that we gave as input. So at the end of the training stage, we tested the networks, and we could actually translate this into mathematical functions to estimate the loads, knowing the positions. We then converted this into some DLL functions in C++ that could be included in any body model thanks to the class template functionalities of the any-body modeling system. So with this surrogate contact model embedded in the full body model, we could then evaluate both the accuracy of the force predictions, but also the speed up in terms of computation time. So as for the accuracy of estimated forces, we saw a very good accuracy if you look at the surrogate and the original contact model estimates. These are represented by the continuous and the dotted line, respectively. And we also provided as a gray line, the experimental force measured by the instrumented prosthesis. So the two curves for surrogate and original model are basically overlapping. So this gives us enough confidence that the actual forces on the medial and lateral side estimated during different activities are actually equivalent. In terms of computation time, we could achieve computation time for a general overground gait trial of about 4.5 minutes using the surrogate model. And this compares to 13.6 minutes when using the default model. So overall, we observed an acceleration of a factor of 3. And we also tested on different activities of daily living, such as rising from a chair or squat. And the trend that we saw were generally 3 times speed up in the computation time when using the surrogate model within the FTK analysis. So the accuracy was the same as for the reference model. So we could conclude that we can replace a surrogate contact model in the original any-body model to speed up computation, which could be of help when performing parametric studies or optimizations. So if you are interested in the details of this, we published a paper on the journal Biomechanical Engineering, which tells all the details on the fitting of the networks and the testing accuracy results. So this brings me then to the second topic of today, which is about clinical applications of patient-specific models. This is done in collaboration with researchers and surgeons from the St. Martin's Clinic in Nijmegen, and also with the orthopedic departments of the Rotterdam UMC. So the topic that we will cover are essentially related to the sagittal alignment of the prosthesis in total knee arthroplasty. So the femoral component can be flexed in the sagittal plane, and the tibial slope is another parameter that can vary in this type of surgery. And we'll see why these are important and what the effects of these parameters are. So to start with, tibial slope is actually an anatomical feature of the anatomical tibia. So it is the degree, the angle in the sagittal plane of the tibial plateau. But during surgery, this angle is often neglected, so the tibial slope is not reconstructed correctly. Typically, a cut is performed on the tibial plateau, and therefore the tibia-femoral joint can result in flexion gap tightness. So basically, the knee cannot flex beyond a certain degree. So to solve for this, surgeons have the tendency to increase the slope. So basically, they try to increase the flexion gap and to achieve higher flexion. However, the effect of this operation intraoperatively is still largely unknown. We then use the patient-specific TKA model that we just presented to investigate the possible effects of tibial slope on the outcome of the prosthesis. So in addition to the previous presented model, we also did some modification. Namely, we replaced the rigid patellar tendon with an elastic tendon to account for some elasticity also in this tissue. Furthermore, we improved the path of the quadriceps muscle so that they could wrap better around the condyles of the femur. We then performed a parametric study with the tibia slope being one of the parameter varied. We varied that in a range between -3 degrees to +9 degrees in the sagittal plane. But we also looked at the referencing technique that can be used intraoperatively to actually change the degree of tibial slope. And this is basically, there are two techniques to achieve this. One is the anterior cortex referencing. The other one is the central of the tibial plateau referencing. And this would be abbreviated as ACR and CPR. So first of all, we looked at the laxity behavior of the knee under different degrees of tibial slope. So we performed simulated laxity tests as they would be performed during a clinical examination. We also looked at different degrees of flexion. So we performed this laxity test with multiple tibial slopes from 0 to 90 degrees of flexion. And these were the results. I'm gonna explain this graph. So the blue bar represents the tibial slope with the anterior cortex referencing, whereas the yellow bar represents the central referencing. And the first row is the results for the IP laxity, and the second row is for the varus valgus laxity. So the general trend that we see is with more slope, we see that the laxity in the AP direction, but also in the varus valgus direction, increases as the tibial slope increases with the ACR technique. And the actual rate of increase is quite dramatic, it's quite important, which we think can lead to instability in the joint. What is different with the CPR technique is that generally the amount of laxity in the tibial-femoral joint is preserved to a very large extent. Therefore, tibial slope has less influence on the laxity, which we think would lead to more stable reconstruction. So this was about laxity, but we also we were also interested in the actual performance during activities of daily living. So we simulated a quite demanding task. So we simulated activities from the data set of the Grand Challenge. And we repeated the analysis with different slope configuration and searching. We looked at the ligament forces first. We saw the general effect of tibial slope being reducing the ligament forces during squat. What you see here are the peak forces recorded during squat. So more slope leads to a decrease in the peak ligament forces. However, the effect of ACR, as also expected from the laxity test, are much more dramatic than the effect of CPR. And we observe here, for instance, with PCL, MCL, and LCL completely slack with the large degrees of slope, which could lead to instability in the tibiofemoral joint. We could also plot the kinematics of the tibiofemoral joint, of the tibiofemoral contact point, in different configurations. So if we condense the results in a single figure, we could actually compare the different tibial slope obtained with the different surgical techniques. And the general trend is that with ACR, the total travel of the contact point on the lateral side increases, whereas CPR essentially preserve the total travel of the contact point, and it produces also a posterior shift of the contact point, which could be beneficial for the knee extensor mechanism. Finally, we looked at the knee loads, essentially the quadriceps force, patellofemoral force indicated by PF, and the quadriceps tendon to femur force indicated with QF. And this is actually a rather interesting parameter because it takes into account the force of the quadriceps tendon, which is exchanged directly with the femur, thanks to the wrapping of the muscle fibers with the flange of the femoral component. So if we take these three components of force into account, we see that quadriceps force is decreasing with more slope, and this is more or less valid with both referencing techniques. However, when we look at the quadriceps tendon to femur force, we see that when using ACR, more slope determines a decrease in this force, whereas CPR keeps this force relatively stable. As a result of this, the patellofemoral force with CPR is reduced much more than with the ACR when the tibial slope is increased. So we think that reduction of patellofemoral force in this patient could be highly beneficial because it helps reducing stress on the patellofemoral joint and therefore pain. So to summarize, we saw some very large effects of tibial slope on laxity and kinematics, especially when using ACR technique. And this is instead different when using CPR techniques because the overall kinematics were much more stable. And CPR techniques came with the advantage of reducing the patellofemoral loads better than did the ACR. So in conclusion, the tibial slope, it is much better to be planned in advance and possibly to be executed using CPR techniques because it leads to more predictable results and it also appears to be beneficial for the overall function of the knee. Again, for further interest or further details about this study, there is a paper published on the Knee Surgery Sports Traumatology Arthroscopy Journal, which you can read for your further understanding. So this brings me to the second topic about sagittal alignment in total knee replacement. and it's about the flexion of the femoral component. So to introduce this problem, I would just say that sometimes the femoral component needs to be downsized to prevent medial-lateral overhang. Therefore, a smaller femoral component typically results in notching of the anterior cortex of the femur. You can see this in this picture when the flange of the component is actually overlapping the bone. So this is also undesired. So surgeons seek for a solution for this problem. And the idea that came was, can we flex the component to prevent this notching? And what actually happens by a biomechanical point of view on this prosthesis. So this would be a simulation of flexion of the femoral component, which by just looking at the alignment seems much better than the notching case. So also in this case, we performed parametric study. We performed a variation of the flexion of the component from 0 to 9 degrees. And we also looked at the combination of the flexion with the size of the implant to possibly understand the interdependence between these two parameters. We simulated another demanding task for patients wearing a prosthesis, namely rising from a chair task from the same data sets. And this gives you a close-up on the actual simulation of the knee joint during rising from a chair. Also in this case, we basically changed the alignment of the prosthesis so to simulate different degrees of flexion and size. We looked at the ligament forces. So in the middle column, we see the reference size, size 4. And if we go to the left, we have size 3, so a smaller size. And on the right, we have a larger size. And different levels of gray represents the flexion of the femoral component. We have the medial patellofemoral ligament in the first row and the posterior cruciate ligament in the second row. So the general effects of flexing the femoral component is that it increases the forces in the ligaments during rising from a chair. However, the effects are much more visible in extension, where the flexion of the femoral component is most evident. And secondly, we can also appreciate that if we downsize from size 5 to size 4, for instance, the force in the ligaments will undergo a serious drop. So this also needs to be taken into account. So finally, we also looked at the knee loads, similarity to the tibia slope study. We see that quadriceps force decreased with more flexion, which is desirable because it means basically that the patient can perform the same motion task with less muscle effort. We looked at the quadriceps femur force, so the force exchanged between the quadriceps tendon and the femur directly by wrapping. And this is increased by more flexion, which eventually results in a reduction of patellofemoral forces. So basically, more flexion of the femoral component determines a shift of the force from the patellofemoral compartment to the quadriceps tendon to femur compartment, which can be also useful to reduce pain. So to summarize these results, we saw that flexion leads to better quadriceps femur load sharing, and as I said, this could be beneficial for patients because it can help preventing pain in the patellofemoral compartment. And as a take-home, we see that the option of downsizing, flexing the femoral component can actually be results in similar results as an upsized component with no flexion, but it comes with advantages of preventing notching Therefore, it's a very valuable option that could be explored to prevent this problem. So I would just like to mention a few limitations of these two studies. First of all, we only looked at one crucial retaining design. So it is generally not possible to extend the results also to other type of TKA prosthesis, because the mechanism for providing stability, for instance, can be rather different. For instance, in posterior stabilized prosthesis, there is no PCL, and the stability inflection is dependent on other parameters. Also, this model does not account for anatomical variability that can be found in patients, especially if we consider very severe deformities. Therefore, this needs to be further evaluated. So this brings me to the last topic of today, which is related to patellofemoral instability. This is a quite common problem in the young and very young population. To have an idea, I have a video here which shows basically a dynamic CT scan of a patient with patellofemoral problems. And you can appreciate that the patella is subluxating to a very large extent, which causes discomfort in the patient. Among the risk factors for patellofemoral instability, we found different factors which sometimes are associated. But one most important is the trochlear dysplasia. So basically, the trochlea of the femur has an irregular shape, which favor the patella to subluxate. Among the other causes, we also find laxity of the medial patellofemoral ligament and muscle insufficiency. So to address this problem, we developed a patient-specific model of patellofemoral joint. So we started from a cadaver specimen for which we had CT scans and also MRI scans of the knee. And we made a specimen-specific model of this cadaver using the similar workflow as used in the Grand Challenge model. We then performed FTK analysis on this specimen-specific model, but with the special attention on calculating patellofemoral cartilage pressure and patellofemoral kinematics. The knee model looks like this. It is composed by a tibiofemoral joint with 6 degrees of freedom, one of which is driven and the rest is governed by force-dependent kinematics. And similarly, the patellofemoral joint has 6 degrees of freedoms, which are all solved using force-dependent kinematics. In addition, we have 4 different pairs of contact surfaces to account for the different possibility that we have for the contact. We have 2 corded cartilage contact pairs, one for the medial and one for the lateral side of the tibiofemoral joint. And then we have also the contact between patellar cartilage and the femur cartilage and the patellar cartilage and the femur bone. So because we are interested more in calculating pressures in the patellofemoral cartilage and the distribution over the surface, we actually want to calculate stresses and strain all over the surface. For that reason, we implemented a new contact model within the Anybody model, which based on the elastic foundation theory. Essentially, if we know the thickness of the elements of the surface, and we know the general technical parameters, such as the Poisson ratio and the Young modulus, it is possible to calculate an equivalent elastic modulus for each element in the surface. so that we can then estimate the contact pressure. So we will make an example using the total knee arthroplasty model, which is the one we used to actually develop this model. To have an idea of how this model, contact model works, we can think of the femoral component as being the slave surface in contact with the master surface, which is the tibial component. And essentially, we are looking for the penetration between the slave surface into the master surface. And we want to get information on the penetration at all possible points in the master surface. So one very brute force approach would be to calculate the distance between all the points of the master and all the points of the slave. But this would be very time consuming and totally inefficient. So what we used is a library for fast intersection and distance computation, which is included in the Seagull C++ library, which makes use of axis-aligned bounding box trees. And these are a special class of trees which are used for accelerating the computation of distance between two colliding objects. So essentially, we have two different times. We have the log time in which the thickness of the master object is computed, and then we can build a tree representation of the slave. And at runtime, when we actually want to simulate the two contacting bodies, we can use this model to compute distance from master to slave. Finally, if we know the distance between all the elements and the slave, we can calculate an equivalent force for each element of the master surface. And summing up the forces for slave and master gives the resultant contact force, which can then be used within force-dependent kinematics analysis. So this was the results that we obtained with this with the same model that we saw before during the performance of a gait analysis. So for the patellofemoral joint and tibiofemoral joint, we computed contact pressure, and this gives much more information than just knowing the center of pressure and the net contact forces, because we actually study the distribution of pressure over the surface. So to go back to the patellofemoral problem with which we started, we took the trochlear dysplasia into account, and we made modifications to the original cadaver model so that we can simulate typical dysplastic trochlea according to a well-known classification made by de Jour. So we use mimics to actually deform the surface of the trochlea, so to resemble the 4 types of trochlear dysplasia as classified. We performed some leg extension trial from 90 degrees to 0 degrees. And we know that the patellofemoral instability has to be expected within the first 30 degrees of range of flexion, so towards extension. We assign material properties to the cartilage, as you see in the slide, and we simulated one healthy case as reference and 4 types of trochlear dysplasia models. And these are typical results of a force-dependent manipulation during this trial. The contact pressure is mapped in color on the patellar surface. So where is actually the inner surface of the patella. And we can see pressure evolves during flexion in this case. We can also assess kinematics of the patellofemoral joint, and comparing with a different type of trochlear dysplasia models. If we see the healthy row, these are the medial lateral rotation, medial lateral shift and tilt of the patella. If we take this as reference, we can calculate the relative rotations of the translations of the patella in the trochlear dysplasia cases. And generally, we see that type B and D produces the most remarkable differences relative to the healthy case. So this gives us clues also on the effect of different trochlear dysplasia on the instability of the patellofemoral joint. We also looked in detail at the contact pressure distributions, and these are preliminary results that we obtained. We clearly see that type B and type D dysplasia results in a very different distributions of contact pressures and also peak values of pressure with respect to the healthy case. So this also helps us to understand the causes of patellofemoral instability. So to sum up, we saw from these preliminary results that trochlear dysplasia had a large effect on patellofemoral cartilage pressure. We could identify two types of dysplasia that most influencing these results. And we could also demonstrate an efficient elastic foundation contact model that is completely embedded in an any-body model of the lower extremity. As limitations, we have now only synthetic trochlear dysplasia models, and we are seeking to actually take real patient data into account, so to account for real shape of the trochleas. Viscoelastic properties, of course, could not be accounted for, although we know that cartilage tissue has a viscoelastic behavior. However, we're not interested here in steady state response. Therefore, in the range of loads that we investigated, even an elastic could be acceptable. So further validation of this elastic foundation model is still required, for instance, by comparing it with the finite element simulations. So this was the end of my presentation. You can find more details in the papers that I mentioned, and I will give the word back to Morten.
Thank you very much, Marco. That was a very nice presentation. Of course, I've seen some of your work before in different pieces, but I've never seen the whole thing put together. So I think it was very, very interesting. So before we get to the questions and answer session, remember that you can ask questions by opening the questions pane and the control panel on the right side. So I'll just say a few words until we get to the questions and answer session. So now you have a few minutes to write questions, and then we will try to address them. Here in the end, I'll also like you to pay attention to some of our upcoming webcasts. I don't know if registrations have opened yet, but on the 28th of February, we'll have a webcast on simulation as a tool for human-centered exoskeleton design. And this will be Anand here from our company who will hold this webcast and present a number of different techniques for exoskeleton design. And on the 15th of March, we have like a webcast on model validation using anatomical reachable 3D workspace. And this is a PhD student from Aalborg University who's going to talk about his work. And it's also related to exoskeleton design, as I remember. Then at the end of March, we are present at CMBBE, which is a conference in Lisbon. So if any of you are attending this webcast, you can you can find us there or meet us there. Just send us an email. And I also like to make a little bit of commercial for a PhD course, which is hosted at Aalborg University on advanced musculoskeletal modeling. So if any of you are starting up projects or new as a PhD student, or even if you are even advanced users, this is a really, really good course to attend. So I can only recommend that. You can also, let's see if I can move on. Yeah, you can also visit our homepage, anybodytech.com, to find these events and dates. And in there, you can also find a publication list of all the Anybody publications that we know of, at least. And it's possible to easily search on this list or pick out topics that you're interested in. So on this list, I think you can also find a lot of Marco's papers. So if you go in and take lower extremity and knee, I'm sure you can find many of Marco's papers in there.